Yes, thank you. Ladies and gentlemen, Mr. Chairman, I've been asked to speak about how to assess optimized macro and microcirculation in splanchnic region. To be honest, I don't know. And there is not very much clear recommendation in that respect, but I will try to go through of this topic. Starting from the very basic, splanchnic means the organs in abdominal cavity, and splanchnic circulation is blood flow to the gastrointestinal organs, stomach, liver, spleen, pancreas, and intestines. So the blood comes, arterial blood, well, you know, comes from celiac axis, superior and inferior mesenteric artery, and then it's collected into portal vein from the superior and inferior mesenteric vein. This is very basic from the medical school. It should be known. The arterial blood supply, surgeons know that well, intensivists not that often know that well, especially if you treat the patients on vascular surgery, abdominal aortic surgery. How is the blood supply to the left column? So there is a tight network of collaterals. So you may basically close the mesenteric inferior artery, and the collaterals take over the business. Splanchnic blood flow takes about 1/3, up to 1/3 of cardiac output, and about 1/5 to 1/3 of oxygen consumption of the body. That's quite remarkable part and should be considered. When we go further to the microcirculation area, then we have microcirculation of liver, intestines. In intestines, we have the intestinal villi. There is a counter exchange of solids, and please pay attention to the oxygen parts of pressure there. In arterioli, it goes down, 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 and there is a counter current exchange of oxygen as well. So in the tip of the villi, the oxygen tension is relatively low, and that makes it highly susceptible to the damage, either from hypoxia or from hypertension or from both, and that's what we observe often in our critically ill patients. Sympathetic blood flow is regulated by sympathetic and parasympathetic activity. The first one gives the vasoconstriction, and the parasympathetic activity gives increased intestinal motility and secretion metabolism, and indirect way to increase the local tissue perfusion. One thing is also, it is important not to forget, and that is the capacitance function of the splanchnic vasculature. We have the arterial side, the venous side. It's quite significant amount of blood there. One may think that there's a spare blood there. In case of hypotonia, in hypovolemia, in hemorrhagic shock, the vasoconstriction uses the blood into the circulation there. So the vasoconstriction gives works through the alpha adrenal receptors in both sides, in arterial and portal side, and that's the so-called spare amount of blood we can effectively move into the circulation. How to assess? How to assess the macrocirculation? How to assess? Okay, we know how to assess the macrocirculation of entire body as such, but when we come to the splanchnic blood flow, it becomes more complicated. For a long time, that was hepatic vein catheterization and Fick principle used. A couple of decades ago already, it is invasive. It needs hepatic vein cannula, blood sampling, and you can actually assess thereby the hepatosplanchnic blood flow. What is good is continuous monitoring possible. You can assess venous saturation. You can assess the venous pressure in hepatic veins, but it has led to the variable results which has been difficult to interpret. So today in current routine is very seldom used. Dye extraction method in the cyanine green, which is available for pulsion monitoring systems, give the extraction of indocyanine green, and that can help you to calculate the liver function and splanchnic function, splanchnic perfusion. The bad thing is it's difficult to differentiate between these two. And ultimately, there is the ultrasound and laser Doppler flow metry available. It's patient-operator dependent, patient characteristics are important there. So there is actually, we must admit, there is no easily applicable method for continuous monitoring of splanchnic blood flow. It is so. We can do that in experimental models, maybe in clinical trials, specific methodology-rich trials, but not in a clinical routine. So what we are left, we have the indirect surrogate parameters, general blood flow as such, cardiac output measurement for sure. If 1/5 or 1/4 of that goes to the splanchnic area, so the entire cardiac output also indirectly reflects what the splanchnic area receives. Intra-abdominal pressures in that context are important since despite there are not that many clinical studies, there are experimental studies, but there are data suggesting that increase in intra-abdominal pressure will lead to the splanchnic blood flow. I'll show you that later on. And we have the abdominal perfusion pressure, which is calculated from mean arterial pressure minus intra-abdominal pressure, and that can give you the idea glue of splanchnic perfusion existing. Finally, in clinical practice, we often remain only with clinical signs, which may suggest that there is insufficient splanchnic blood flow. Abdominal pain, abdominal distension, bowel paralysis, feeding intolerance, diarrhea, melena, they can be indirect signs of insufficient blood flow in splanchnic area. And on top of it, in side of it, it's radiology investigations showing the different anatomical lesions which might be of relevance. The biomarkers about how to assess whether the blood flow to the splanchnic organ has been sufficient or not, the lactate we know well. Bruno told about basic SAS, again, acidic blood, but these are of course non-specific. You can't tell that this is coming from a splanchnic region. We have some new promising biomarkers, not yet in clinical routine. The research group from Netherlands has reviewed recently that and put it forward like intestinal fatty acid binding protein, the most promising in that list as for use to detect ischemic lesion of the bowel. But that is ischemic lesion. It's not that we can monitor the perfusion continuously or dynamically of your particular patient. So that was macrocirculation. Do we have something better in microcirculation? Can we assess that better in splanchnic area? Unfortunately, not. In clinical practice, often that what we have left, capillary refill, mottled skin, and that's something which we use in clinical practice. The mottled skin, if something that is on the skin, maybe you'll be quite sure that similar problems are there. How we can measure microcirculation? We have two ways. We have gastric tonometry, handheld video microscopes. The gastric tonometry, again, has been investigated quite extensively, maybe decades ago. And the idea is that there is the balloon in the stomach, and then this CO2 content in the balloon is measured with the simultaneous measurement of blood gases, and intraluminal pH can be then calculated from Henderson-Hasselblad equation, and then that will reflect the intramucosal pH. It is possible, and that reflects the gastric mucosal microcirculation. There are some limitations. It needs some time to equilibrate CO2 between the balloon and the lumen. There is acid secretion, enteral feeding, which interfere with the results. Handheld video microscopes, very promising, very interesting. You hear about them a lot in intensive care meetings. There are different methodologies, first, second, third generation of devices. And there are about 600 articles about clinical experimental use of video microscopes to check and to assess microcirculation. Very interesting. However, there are a lot of questions around and especially because this is assessment of videos, it is difficult whether it has been done manually or automated. What is the quality of video taken from sublingual area? There are some ideas that sublingual area reflects the changes in splanchnic areas, because this in development of organism is the same area. We may see what happens in sublingual area and think that the same occurs in splanchnic area. However, it's just recently stated in recommended consensus document of European Society of Intensive Care Medicine. A lot of studies, however, the further developments are needed prior to its integration into routine clinical practice of sublingual microscopy. It's a very particular, specific population cohort of patients who have ileostoma. There, we can directly assess the microcirculation of the bowel. How to optimize then? Now we have problems with assessment of splanchnic circulation, macrocirculation and microcirculation. Then now we come to the optimization. First thing, I think what we need to consider, it is what are the changes of splanchnic blood flow in critical conditions what we deal with, or in response of common therapies we apply, either fluids, vasopressors, or inotropes. With respect to critical conditions, it is shown and pretty well known the sepsis and other forms of distributive shock are associated with increased in splanchnic blood flow and also with increased splanchnic oxygen demand. Both are increased, the blood flow to the splanchnic area and the oxygen demand, oxygen use in that area. And the lower graph shows the splanchnic blood flow, and it is thought that it depends on the severity of sepsis or this distributive condition, how high this splanchnic blood flow goes. In low flow states, in cardiogenic shock, hypovolemia, splanchnic blood flow is decreased and oxygen demand is covered by increased oxygen extraction ratio, as shown in this graph. Here we compare the patients after cardiac surgery and low flow, and we see really low flow on splanchnic area and high extraction ratio, and vice versa in septic shock and vasopressors. We see septic shock, high splanchnic blood flow, but the extraction rate is low. So and this is different from the cardiogenic shock. What about our treatments, or what we do in intensive care? What about feeding? Does the feeding influences blood flow in abdomen? Yeah, we know that intuitively that it is so, and indeed has been shown in studies. Also, in healthy volunteers, before fasting and after the meal, the splanchnic blood flow is increased and splanchnic oxygen utilization is increased. Both are increased. The nutrition increases the splanchnic blood flow and increases the oxygen demand. And that's so for the enteral feeding. With respect to parenteral feeding, this is shown here in a trial from Dr. Gatz and co-authors. The enteral nutrition before and after nasogastric feeding, the blood flow is increased in splanchnic area. But if we look on the parenteral nutrition, no changes. That is something to consider if we are dealing with patients we think he or she has critical mesenteric perfusion or splanchnic perfusion in that particular time moment we're dealing with him. Abdominal hypertension. Here it is the study from Manu, which shows quite nicely in the patients that intra-abdominal hypertension, increase in intra-abdominal pressure will lead or is associated with drop in hepatosplanchnic blood flow. And that can be in different ways, either because of decrease in cardiac output or direct effect on the splanchnic area. Here we see the splanchnic blood flow assessed by the idiocyan green disappearance rate. This is here conversely related to the mean intra-abdominal pressure. The higher is the pressure, the lower is the disappearance rate, so means the worse is the splanchnic circulation. And here is the same for the abdominal perfusion pressure. The better is the abdominal perfusion pressure, the better is the splanchnic blood flow. And that's one thing to take home. It's the intra-abdominal pressure and splanchnic blood flow. Here is in experimental animals, the intra-abdominal pressure of 20 or 30, these are 25 peaks. Intra-abdominal hypertension was used by Kapno peritoneum. The 30 millimeters of mercury is really high. 20 millimeters of mercury is something more relevant to our clinical practice, but what we see is, again, that pH, intramural, intragastric pH, that was decreased while the animals were suffering 5 hours of intra-abdominal hypertension. So intra-abdominal increase in intra-abdominal pressure lead to decrease in perfusion pressure and decrease of microcirculation in splanchnic area. So this is another thing, and was accompanied with increases systemic lactate. Of course, with the pressure of 30 for 5 hours, this is quite critical. We wouldn't see that similar in clinical practice, but with the 20 we would. What the vasopressors and inotropes do for splanchnic circulation? Variable effects depending on volumic status and underlying clinical disease. Septic shock and increase and use of vasopressors, and you see here from the group of Jukka Takala, they did a series of these experiments or these clinical trials in Finland. Cardiac index, you see quite high, and the vasopressor, adding the vasopressor still increased the splanchnic blood flow, but please pay attention to the absolute values here. When it's after cardiac surgery and you give the dobutamines in lower edge of cardiac index and splanchnic blood flow, the effect is more straightforward to the similar increase in both cardiac output and splanchnic blood flow. What the fluids do to splanchnic microcirculation? If we speak about microcirculation, it is very hard to have the convincing evidence from the scientific literature today. There are very different settings: hemorrhage, endotoxin-induced sepsis, mainly experimental animal studies, because splanchnic microcirculation is so difficult to assess in a living patient. It can be done in animals. Here is male Wistar rats, hemorrhage 30 mils per kilo, and were compared with a normal saline, hypertonic saline, gelatin and Hess, and all the solution restored mean arterial pressure after the hemorrhage. However, the intestinal microcirculation, which is seen, this is intestine, and this is here is a good microcirculation here, and it was well resuscitated with hypertonic saline and colloids, but not with isotonic crystalloid. However, colloids were associated with greater formation of renal reactive oxygen species in vivo after reperfusion, so there are pros and contras, good effect, negative effect, and it's not that conclusive. Macro versus microcirculation. This experiment is on the anesthetized sheeps. They were receiving endotoxin, where fluid resuscitated, and macrocirculation here assessed with mean arterial pressure and superior mesenteric arterial blood flow. And in endotoxemia, the splenic blood flow went up as was expected, and mean arterial pressure went down. Microcirculation, and then they give norepinephrine for last 1 hour here and restored mean arterial pressure. This didn't change the superior mesenteric artery flow, and surprisingly, if the splenic blood flow was increased, then the microcirculation in the mucosa or muscular layer of the bowel was decreased and was not changed with the application of noradrenaline. So there is clear loss of coherence.
1 minute, Joe.
Yeah, between macro and microcirculation. So there is difficult to assess both of them. How to optimize? Maybe we should remember how macrocirculation in splenic region is influenced. So the take home is 1/3 of cardiac output goes to splenic. There is splenic microcirculation via video microscopy, maybe in the future. Fluids definitely play a role in the splenic area, and we should be aware of the risks of intra-abdominal hypertension in that respect. Thank you for your attention.